Welcome to Chapter 3 of Pediatric Ophthalmology and Strabismus, where we'll be focusing on motor physiology. In this chapter, we're going to build a framework for how eye movements are generated, controlled, and coordinated. The goal is to understand how the extraocular muscles and their neural inputs work together to keep the eyes aligned and moving smoothly. This motor foundation is critical because disorders of ocular alignment are not just mechanical problems. They reflect how the brain plans, executes, and adapts eye movements. As we go through this chapter, we'll focus on principles that explain normal eye movements first, and then use those principles to make sense of strabismus and its clinical patterns. This slide highlights the core motor principles that everything else in this chapter builds on. Sherrington's law states that when an agonist muscle contracts, its antagonist must relax. This law governs innervation for ductions, meaning monocular eye movements. Anytime a single eye moves, one muscle turns on while its opposing muscle turns off. When strabismus worsens in a specific direction of gaze, that finding points to a mechanical explanation. It may be due to weakness of the agonist muscle, restriction of the antagonist muscle, or a combination of both. Thinking in terms of agonist-antagonist pairs helps localize the problem. Evaluating all 6 cardinal positions of gaze is critical because it allows us to isolate and understand the primary action of each extraocular muscle. Each gaze position selectively stresses specific muscles, revealing patterns of weakness or restriction. Herring's law complements this by describing how the two eyes move together. It states that yoked muscles receive equal innervation during conjugate gaze shifts. This law governs versions or binocular eye movements and explains why increased effort to move one eye also affects its yoked partner. Together, Sherrington's and Herring's laws form the physiological foundation for understanding eye movements and diagnosing patterns of strabismus. This slide introduces the basic ways the eye can rotate in space. Horizontal eye movements occur around a vertical axis. These rotations produce medial and lateral gaze, moving the eye left or right. Vertical eye movements occur around a horizontal axis. These rotations are responsible for upward and downward gaze. Torsional movements occur around the visual axis, which runs straight through the pupil. These rotations produce intorsion and extorsion, where the top of the eye rotates inward toward the nose or outward toward the temple. Keeping these 3 axes in mind is essential because every extraocular muscle movement can be broken down into some combination of horizontal, vertical, and torsional rotation. This slide defines how we describe and organize eye positions during an exam. The primary position is straightforward. It's straight-ahead fixation, with the eyes looking directly forward. This is the reference point for all other gaze positions. Secondary diagnostic positions involve moving the eyes in one direction at a time. These include straight up, straight down, right gaze, and left gaze. These positions help isolate basic vertical and horizontal actions. Tertiary diagnostic positions combine vertical and horizontal movement. These are the 4 oblique gaze positions, along with right and left head tilt positions, and they are especially useful for evaluating the oblique muscles. The 6 cardinal positions of gaze are upright, up left, down right, and down left. Each of these positions corresponds to the primary fields of action of specific extraocular muscles. By testing these positions systematically, we can determine which muscles are functioning normally and which may be weak or restricted. This structured approach is what allows gaze testing to move from simple observation to precise muscle localization. This slide explains why extraocular muscle actions stay relatively consistent across different gaze positions. Extraocular muscles have broad insertions on the globe, and that broad attachment helps stabilize the eye. Because of this, the action of a muscle doesn't change dramatically as the eye moves into different positions of gaze. A useful example is the medial rectus during upgaze. As the eye looks upward, the medial rectus insertion effectively shifts upward with the globe. At the same time, the inferior fibers of the muscle tighten while the superior fibers slacken. This redistribution of tension shifts the net force vector back toward its original orientation. The result is that the medial rectus continues to act primarily as an adductor, even as eye position changes. This stabilizing mechanism allows eye movements to remain predictable and coordinated across the full range of gaze. Here we introduce the concept of muscle pulleys and why they matter for eye movement control. The rectus muscles pass through consistent openings in Tenon's capsule, and importantly, those openings remain stable regardless of eye position or even after surgical repositioning of the muscle insertion. This means the effective path of the muscle is not determined only by where it inserts on the globe. Surrounding these openings are orbital connective tissue sheaths, which function as muscle pulleys. These pulleys act like fixed guides that redirect the muscle's line of pull. By guiding the muscle path from the orbital apex to the globe, the pulleys help maintain consistent muscle actions across different gaze positions. This pulley system explains why extraocular muscle function remains predictable and why changes in eye movement can occur even when muscle insertions themselves are anatomically intact. In primary position, each extraocular muscle wraps around the globe for several millimeters before it inserts into the sclera. The portion of the muscle that stays in contact with the globe is called the arc of contact. The point where the muscle first touches the globe acts as the effective insertion, which is what actually determines torque. As the muscle contracts and the eye rotates toward it, this effective insertion moves forward and the arc of contact shortens. Despite that shift, the muscle stays tangent to the globe, allowing torque to be preserved throughout the movement. This slide introduces motor units and how we study their activity in eye muscles. A motor unit consists of a single motor nerve fiber and all of the muscle fibers it innervates. When that nerve fires, every muscle fiber in its motor unit contracts together, producing a coordinated mechanical response. Electromyography, or EMG, records the electrical activity generated by these motor units. By measuring when and how strongly motor units fire, EMG allows us to assess muscle activation patterns directly. In extraocular muscles, EMG is particularly useful for studying both normal and abnormal innervation. It helps distinguish whether an eye movement disorder is due to altered neural input or a primary muscle problem, which is critical for understanding and managing strabismus. This slide highlights a practical clinical application of EMG in strabismus care. A portable EMG device can be attached to an insulated needle and used to guide botulinum toxin injections into extraocular muscles. As the needle advances, EMG activity confirms when the tip is within the target muscle. This technique helps accurately localize the correct muscle within the orbit, which is especially important given the close proximity of multiple extraocular muscles. EMG guidance is particularly useful in patients who have had prior extraocular muscle surgery, where normal anatomy may be altered and visual landmarks are less reliable. By confirming muscle activity in real time, EMG increases precision and reduces the risk of injecting the wrong muscle. This slide explains how extraocular muscles generate stronger contractions during eye movement and fixation. Recruitment refers to the progressive activation of additional motor units to increase contraction strength. Rather than relying on a single motor unit, the muscle brings more units online as more force is needed. As the eye moves farther into abduction, additional lateral rectus motor units are recruited. Each newly activated motor unit adds to the total pulling force, allowing the eye to continue moving smoothly toward the target position. Once the eye reaches sustained abduction, force is increased in a different way. The firing frequency of each active motor unit rises until it reaches a peak rate. Together, motor unit recruitment and increased firing frequency allow the eye to both move into position and hold that position steadily. This slide further defines eye movements. We reviewed versions, but now we are talking about ductions, which are monocular. Ductions are rotations of a single eye, independent of what the other eye is doing. They describe the basic directions an individual eye can move. Adduction refers to rotation of the eye toward the nose, while abduction refers to rotation toward the temple. Vertical movements are described as elevation and depression. Elevation, also called supraduction or circumduction, is upward rotation of the eye. Depression, also called infraduction or deorsumduction, is downward rotation. Torsional movements describe rotation around the visual axis. Intorsion or encycloduction occurs when the superior pole of the eye rotates nasally. Extorsion, or X-cycloduction, occurs when the superior pole rotates temporally. These terms are the building blocks of ocular motor physiology, and they allow us to describe eye movements precisely and consistently during both examination and diagnosis. This slide defines the roles that different muscles play during monocular eye movements. The agonist is the primary muscle responsible for producing a specific movement. When an eye moves in a given direction, the agonist is the muscle doing most of the work. A synergist is a muscle in the same eye that assists the agonist in producing that movement. Synergists contribute additional force or help refine the direction of motion. The antagonist is the muscle in the same eye that produces the opposite movement. During normal eye movement, the antagonist relaxes as the agonist contracts, allowing smooth and efficient motion. Understanding these roles is essential for applying Sherrington's law and for localizing pathology when eye movements are limited or asymmetric. This slide focuses on Sherrington's law of reciprocal innervation. Sherrington's law states that increased innervation to an agonist muscle is paired with decreased innervation to its antagonist. This reciprocal relationship allows eye movements to be smooth and efficient without unnecessary resistance. For example, during right eye adduction, innervation to the medial rectus increases so the eye can move nasally. At the same time, innervation to the lateral rectus decreases, allowing that muscle to relax and not oppose the movement. This principle is fundamental to monocular eye movements and explains why weakness or restriction of a single muscle can disrupt normal ocular motility patterns. This slide defines what we mean by a muscle's field of action. The field of action is the cardinal gaze position where the effect of a given extraocular muscle is most evident. It's the position that best isolates that muscle's primary contribution during exam. For the horizontal rectus muscles, the concept is straightforward. The lateral rectus produces abduction, and its field of action is abduction. The medial rectus produces abduction, and its field of action is abduction. In both cases, the direction of rotation matches the field of action. Vertical muscles behave differently. For these muscles, the direction of rotation does not equal the field of action. Their vertical effects are most evident only in specific gaze positions, which is why testing them requires moving the eye into particular cardinal positions. This distinction is critical for accurate motility testing and muscle localization in strabismus evaluation. Building on the definition of field of action, these examples show how it applies to the oblique muscles. The inferior oblique both abducts and elevates the eye. While it contributes to both movements, its elevating effect is best observed when the eye is adducted and then elevated. That gaze position isolates the inferior oblique's vertical action. The superior oblique also abducts the eye, but instead of elevating, it depresses. Its depressive action is best seen when the eye is adducted and then depressed. Testing in that position brings the superior oblique into its primary field of action. These examples illustrate why vertical muscle testing requires placing the eye in specific horizontal positions rather than simply asking the patient to look straight up or down. Once you know a muscle's field of action, gaze-dependent deviations become much easier to interpret. If a deviation worsens when the patient looks in a specific direction, that pattern suggests a problem in the muscle that normally moves the eye in that direction. The issue may be true weakness of that muscle, restriction of its antagonist, or a combination of both. This framework is what allows you to move from simply describing misalignment to localizing the underlying pathology during a motility exam. With that framework in place, we can look specifically at the horizontal rectus muscles. In primary position, the medial rectus and lateral rectus act purely in the horizontal plane. Their primary and essentially exclusive action is horizontal duction, adduction for the medial rectus and abduction for the lateral rectus. In some patients, there is evidence of compartmentalized innervation within the horizontal rectus muscles. Different portions of the muscle may be activated independently. This compartmentalization may explain why small vertical movements are occasionally observed during what should be purely horizontal gaze shifts. Once we move from the horizontal recti to the vertical rectus muscles, their actions become more complex. The primary action of the superior rectus is elevation, and the primary action of the inferior rectus is depression. In primary position, both muscles are designed to move the eye vertically. Their line of pull, however, is not perfectly vertical. It is inclined about 23 degrees to the visual axis in primary position. Because of that oblique pull, contraction of these muscles produce secondary torsional effects. The superior rectus causes intorsion, while the inferior rectus causes extorsion. In addition, both muscles have a tertiary adducting effect due to the nasal component of their pull. After the vertical rectus muscles, the obliques follow a different set of rules. The oblique muscles are oriented about 51 degrees to the vertical axis, which fundamentally changes their function compared with the recti. Because of this orientation, their primary action is torsion rather than vertical movement. The superior oblique produces intorsion, while the inferior oblique produces extorsion. Vertical movement is a secondary effect for both muscles. The superior oblique contributes to depression of the eye, particularly when the eye is adducted, and the inferior oblique contributes to elevation, again most evident in adduction. Here, we're shifting from what each muscle can do to when that action is most visible. As the eye moves, the contribution of each extraocular muscle changes because its plane of pull rotates relative to the visual axis. In every cardinal position of gaze, muscle effectiveness depends on how closely the muscle's line of action aligns with the axis of rotation for that movement. By placing the eye in specific gaze positions, certain muscle actions are minimized while others are emphasized. In horizontal gaze, this isolates the medial and lateral rectus muscles. In vertical gaze, alignment allows the superior and inferior rectus and oblique muscles to express their vertical actions more clearly. This is why testing eye movements through the 6 cardinal positions is so powerful clinically. It functionally isolates each extraocular muscle and reveals weakness, restriction, or imbalance that may not be apparent in primary position alone. Building directly on the idea of isolating muscle function with gaze alignment, the horizontal rectus muscles are the most straightforward to test. In primary position, the medial rectus and lateral rectus lie in a single horizontal plane that is already aligned with the visual axis. Because of that alignment, their action remains purely horizontal, without meaningful vertical or torsional contribution. Testing is therefore simple and intuitive. Asking the patient to move the eye nasally isolates the medial rectus, while movement temporally isolates the lateral rectus. The size and smoothness of these horizontal excursions give a direct assessment of horizontal rectus strength and function. Once we move beyond the horizontal rectus muscles, the picture becomes more complex. The vertical rectus and oblique muscles do not act in a single plane, and their pull changes with eye position. A key reason for this is anatomy. Their insertions lie anterior to the globe's center of rotation. Because of that anterior insertion, contraction produces a combination of vertical, torsional, and horizontal forces, rather than a pure movement in one direction. Building on that idea, we can isolate the vertical rectus muscles by changing gaze position. Their vertical action is best seen when the visual axis is aligned with the muscle plane. That happens at about 23 degrees of abduction. In this position, the superior rectus functions as a pure elevator and the inferior rectus as a pure depressor. If we move the eye further into adduction, the situation changes. When the visual axis becomes perpendicular to the muscle plane, around 67 degrees of abduction, the vertical effect is minimized and torsion dominates. In that setting, the superior rectus acts mainly as an intorter and the inferior rectus as an extorter. In practice, the eye cannot adduct fully to 67 degrees, so even in maximal abduction, the superior and inferior rectus muscles never lose their vertical component completely. Let's look at the vertical rectus muscles again, this time visually, starting with the superior rectus. Starting in primary position on the left, the superior rectus pulls at an angle to the visual axis. Because of that oblique pull, it produces a combination of elevation, intorsion, and a small amount of adduction. When the eye moves into about 23 degrees of abduction, shown in the middle image, the visual axis lines up with the muscle plane. That alignment strips away the torsional and horizontal components, so the superior rectus now acts almost purely as an elevator. This is why we abduct the eye to test superior rectus function clinically. On the right is the theoretical extreme, about 67 degrees of adduction, where the visual axis would be perpendicular to the muscle plane. In that configuration, vertical action drops out and torsion dominates, so the superior rectus functions primarily as an intorter, with only a minor adducting effect. This position isn't physiologic, but it illustrates why vertical rectus muscles always retain some vertical action in real patients. Here the same concept applies, just mirrored for the inferior rectus. In primary position, the inferior rectus also pulls at an angle to the visual axis, so its action is mixed. You get depression as the main vertical effect, along with extorsion and a small adducting component. When the eye is abducted, demonstrated in the middle image, the visual axis aligns with the muscle plane. In this position, the inferior rectus acts as a near pure depressor. This is why we abduct the eye when we want to isolate inferior rectus function on exam. The rightmost image shows the non-physiologic extreme of about 67 degrees of adduction, where the visual axis would be perpendicular to the muscle plane. Vertical action is minimized and torsion dominates, so the inferior rectus functions primarily as an extorter, with only minor adduction. As before, the eye can't actually reach this position, but it helps explain why inferior rectus always retains some depressive action in real gaze positions. Building on the vertical rectus discussion, the obliques behave differently because their insertions lie posterior to the globe's rotational center. In primary position, the oblique muscle planes sit at about a 51-degree angle to the visual axis. Because of that geometry, torsion is the dominant effect, with a secondary vertical action and a smaller abducting component. When the eye moves into about 51 degrees of adduction, the muscle plane lines up with the visual axis. In that position, the vertical action is maximized, which is why we adduct the eye to test inferior oblique elevation and superior oblique depression. As the eye moves instead into about 39 degrees of abduction, the visual axis becomes perpendicular to the oblique muscle plane. Vertical effects fall away and the action becomes predominantly torsional. Here, we're looking at how the superior oblique changes its effect as gaze shifts. In primary position, the superior oblique muscle plane sits about 51 degrees off the visual axis. Because of that angle, its strongest effect is in torsion, with depression as a secondary action and abduction as a smaller tertiary effect. When the eye moves into about 39 degrees of abduction, the visual axis becomes nearly perpendicular to the superior oblique's muscle plane. In this position, the vertical component drops out, and the muscle acts mainly as an intorter with some abducting effect. This is where torsion is most isolated. When the eye moves into about 51 degrees of adduction, the muscle plane lines up with the visual axis. Now the vertical component is maximized, and the superior oblique functions primarily as a depressor, with intorsion still present. This is why we adduct the eye to test superior oblique depression clinically. The key idea is that the muscle hasn't changed, only the gaze position has, and that alone reshapes what action we see. This is the same framework as the superior oblique, just flipped for the inferior oblique. In primary position, the inferior oblique muscle plane is also about 51 degrees relative to the visual axis. Because of that angle, its strongest action is extorsion, with elevation as a secondary action and abduction as a smaller tertiary effect. When the eye moves into about 39 degrees of abduction, the visual axis becomes nearly perpendicular to the inferior oblique's muscle plane. In this position, the vertical component fades and the muscle acts mainly as an extorter with some abducting effect. This is where torsion is most isolated. When the eye moves into about 51 degrees of adduction, the muscle plane lines up with the visual axis. That alignment maximizes the vertical component, so the inferior oblique now functions primarily as an elevator, with extorsion still present. Clinically, this is why we adduct the eye to test inferior oblique elevation. Same rule as before. The muscle doesn't change. Gaze position determines which action shows up the most. Here is a chart summarizing all of the muscle actions referenced to the primary, straight-ahead position, which we went over in the last couple of slides. You can pause here to go over the chart, But otherwise, I will not spend time going through these actions. I will say, though, a useful pattern to remember is that superior muscles intort, inferior muscles extort, rectus muscles adduct, and oblique muscles abduct. Okay, now let's talk about versions, which refers to binocular eye movements, meaning both eyes move together in the same direction. When both eyes move to the right, this is called right gaze, or dextroversion. When both eyes move to the left, this is left gaze, or levoversion. Upward movement of both eyes is called elevation, also known as circumversion, while downward movement of both eyes is depression, or deorsimversion. There are also torsional versions. In dextrocycloversion, the superior poles of both eyes rotate toward the patient's right. In levocycloversion, the superior poles of both eyes rotate toward the patient's left. When the eyes move together, specific muscles in each eye are paired to produce that movement. These are called yoke muscles, one muscle in each eye that work together to move the eyes into the same gaze position. For example, during right gaze, the right lateral rectus and the left medial rectus contract together as a yoke pair. Herring's law explains how this coordination happens. It states that yoke muscles receive equal and simultaneous innervation for a given direction of gaze. Importantly, the amount of innervation sent to both eyes is determined by the fixating eye. This has important clinical implications in paralytic or restrictive strabismus. The primary deviation is measured when the sound eye is fixing, which reflects the baseline misalignment and is measured with the prism placed over the affected eye. The secondary deviation is measured when the affected eye is forced to fixate. Because extra innervation is required to move the weak or restricted eye, the yoke muscle in the fellow eye receives that same increased signal, producing a larger deviation. This is why the secondary deviation is greater than the primary. This figure demonstrates the difference between primary and secondary deviation in a patient with a left elevation deficit. In the first image, the patient attempts upgaze, and the left eye shows limited elevation, revealing the underlying paresis. In the second image, the patient is in primary position while fixating with the normal right eye. The left eye is hypotropic, and this measured misalignment represents the primary deviation. In the third image, fixation is switched to the paretic left eye. To hold fixation, increased innervation is required. That same increased signal is sent to the yoke muscle in the right eye, causing the right eye to elevate excessively. The resulting larger right hypertropia is the secondary deviation. This illustrates why in paralytic strabismus, the secondary deviation is always larger than the primary, directly reflecting Herring's law of equal innervation. We now shift from conjugate movements to vergences, which are binocular eye movements in opposite directions. With convergence, both eyes move nasally toward a near target, and the medial rectus muscles act as the paired movers. With divergence, both eyes move temporally away from each other, driven by the lateral rectus muscles. Vergence can also occur vertically, where one eye elevates while the other depresses. There are torsional vergences as well. In encyclovergence, both superior poles rotate nasally. In excyclovergence, both superior poles rotate temporally. Unlike versions, vergences are not governed by yoke muscles moving the eyes together, but by coordinated opposing movements to maintain binocular alignment. Next is accommodative convergence, or AC, and how it's quantified by the ACA ratio. AC is one component of the near reflex, along with accommodation itself and pupillary constriction. Every diopter of accommodation generates a predictable amount of convergence, and that relationship is expressed as the ACA ratio. When the ACA ratio is high, accommodation drives excessive convergence, so patients show more esotropia at near than at distance. When the ACA ratio is low, accommodative effort produces relatively little convergence, and the eyes may appear less esotropic or even exotropic at near. This relationship is key for understanding distance-near discrepancies in strabismus. Beyond accommodative convergence, there are several other mechanisms that help align the eyes. Fusional convergence is driven by retinal image disparity and fine-tunes alignment to maintain single binocular vision. Proximal, or instrument convergence, is triggered simply by the awareness that an object is near, something commonly encountered during microscope use. Voluntary convergence refers to conscious activation of the near reflex. Finally, tonic convergence represents baseline innervational tone that keeps the eyes slightly converged when awake. Clinically, when tonic convergence is lost under general anesthesia, an esotropic deviation may appear smaller, or even shift toward exotropia. In contrast to convergence, fusional divergence moves the eyes temporally to overcome binasal retinal disparity. There is also fusional vertical vergence, where one eye elevates while the other depresses to reduce vertical disparity and maintain single vision. These mechanisms allow fine alignment when horizontal or vertical image mismatch would otherwise disrupt fusion. Fusional cyclovergence fine-tunes torsion to reduce torsional disparity between the two eyes. Within cyclovergence, both superior poles rotate nasally, while excyclovergence rotates them temporally. Unlike horizontal and vertical vergence, the motor range of cyclovergence is quite limited, even with training. As a result, the visual system relies heavily on sensory adaptation to maintain single vision, especially in patients with chronic torsional misalignment or long-standing strabismus. This helps explain why some patients tolerate torsional deviations surprisingly well, while others experience significant torsional diplopia with relatively small changes. Supranuclear control refers to the higher-level systems that sit above the ocular motor nuclei and coordinate eye movements as a whole. Rather than moving individual muscles, these systems organize patterns of movement across both eyes. They're responsible for initiating gaze shifts, stabilizing images during head motion, and maintaining steady fixation on a target. Different supranuclear pathways specialize in different tasks, such as saccades, smooth pursuit, vergence, and fixation. Together, these systems ensure that eye movements are fast, accurate, coordinated between the two eyes, and well-matched to visual and behavioral demands. The saccadic system is responsible for generating very fast eye movements, reaching velocities of roughly 400 to 500 degrees per second. These movements allow the visual system to rapidly redirect gaze so that objects of interest are placed directly onto the fovea. Functionally, saccades let us scan the environment and jump quickly from one target to another rather than smoothly tracking motion. Because the eye and surrounding orbital tissues have significant viscosity, saccades require a strong, brief burst of extraocular muscle force to initiate movement. This rapid pulse of innervation is what allows the eye to overcome orbital resistance and move almost instantaneously to a new position. In contrast to saccades, smooth pursuit eye movements are designed to track moving targets and keep their image centered on the fovea. These movements are slower and more controlled, with peak velocities limited to about 30 to 60 degrees per second. Smooth pursuit has a shorter latency than saccades, but cannot be generated without a moving visual target. Closely related is the optokinetic system, which helps stabilize vision when the entire visual field is moving, such as when looking out of a car window. This system combines smooth pursuit in one direction with a rapid corrective movement in the opposite direction, producing optokinetic nystagmus. Clinically, the optokinetic response is especially useful because it doesn't require patient cooperation, making it valuable for assessing visual function in infants and young children, as well as in conditions like ocular motor apraxia. The vergence system is another supranuclear pathway, but it works very differently from the gaze systems we've talked about so far. Instead of moving both eyes together, vergence controls disconjugate movements, where the eyes move in opposite directions. This is what allows us to shift focus between far and near targets. Vergence movements are slower and more sustained than saccades or smooth pursuit, and they're driven by binocular visual demands rather than spatial targets. They're closely tied to depth perception, fusion, and the near response, and they can operate independently of horizontal or vertical gaze commands. What's interesting is that unlike the saccadic and pursuit systems, the supranuclear control of vergence is still not fully mapped. We understand the motor output to the extraocular muscles reasonably well, but the higher-level control networks are less clearly defined. Clinically, this explains why vergence problems often show up during near tasks like reading or prolonged fixation, even when other eye movement systems appear normal. After vergence, the last major supranuclear system to understand is the vestibulo-ocular system, which is fundamentally about keeping vision stable when the head or body moves. Its primary job is image stabilization. When the head moves, the eyes automatically move in the opposite direction so the image stays fixed on the retina. This system is driven primarily by labyrinthine input from the inner ear. The semicircular canals detect angular acceleration, while the utricle and saccule detect linear acceleration and head position relative to gravity. That vestibular information is rapidly relayed to the ocular motor nuclei to generate compensatory eye movements. Importantly, cervical and neck proprioceptors also contribute, allowing the system to account for head-on-body movement, not just motion through space. This becomes especially relevant in situations where vestibular input is impaired or when the head and trunk move independently. Clinically, the vestibulo-ocular system is the most important reflexive gaze stabilizing mechanism. It operates continuously, even in darkness or when visual targets are absent, and failures of this system produce oscillopsia, imbalance, and characteristic patterns of nystagmus. Thank you for your attention. I hope this overview clarified how extraocular muscles and supranuclear control systems work together to produce precise, coordinated eye movements. Understanding these principles provides a framework for localizing pathology and interpreting clinical findings.